So I wanted to explain the risk score that we're using in the TACTIC trial. We are aware that TACTIC is a clinical trial that is using immune modulation to treat a cohort of patients with an infectious disease. Whilst it's very clear that some of these people have very severe disease courses, many people recover without sequelae, and we wanted to make sure that we are recruiting patients in whom it is worth taking the additional risk of using immune modulation, in a cohort in whom there's genuine equipoise about what we should treat them with. To do this, we initially looked at the first 200 patients admitted to King's College Hospital and used their data to build a risk prediction model. We've then validated that subsequently in a much larger cohort with over 1,200 patients. The risk score, as you can see on the screen here, contains 8 items. There's a chest radiograph severity score, and we're going to cover that separately. There is a few components which are about the patient. Their ethnicity, saying non-white ethnicity, their age over 40, also comorbidities, the presence of hypertension, diabetes, and then some laboratory parameters. The abnormalities in neutrophil counts above 8 and a CRP above 40. And I know many of you will say, well, what about lymphocyte counts? We did look at lymphocyte counts in the modelling. We've chosen the neutrophil on its own as a standalone item because it performed better in the models we developed. Each of these items scores 1 point. You then get a total score up to a maximum of 8 points. We are looking to recruit patients who score 4 or more into the TACTIC trial, or patients who score 3 or more, where one of those points is due to the X-ray severity scoring system. The risk score, as you can see from the graph here, shows that as your score incrementally rises, the risk of requiring critical care support or dying goes up. The cut point we have chosen of 4 or 3 if the radiographic severity is one of those items is at a threshold at which we believe the risk of therapy is definitely justifiable given the risk of the underlying disease. We're now going to talk about the chest radiograph scoring system for TACTIC for the clinical trial. I've got with me today Dr. Mike Waller. Mike's one of the chest physicians at King's College Hospital in London. He's an expert in cystic fibrosis and bronchiectasis and also lung infections. Mike, you've also been on the front line since all this started. Thanks for joining. First up, can I just ask you, just seeing patients with COVID, chest radiograph changes, what are some headline features you see on the radiographs?
Sure. So firstly, there are no pathognomonic diagnostic changes. What we seem to notice are often bilateral, peripheral, maybe symmetrical infiltrates, and we're talking perhaps linear consolidation.
What about other features, hilar nodes or?
Yeah, no, so very early on we've not noticed any hilar changes, bilateral nodes, pleural effusions, lobar changes. I think in fact if I started noticing these on a patient's chest film, I may want to think of another disease process other than COVID that is contributing to this patient's symptoms.
So can I just pick up on that? So what about diseases like cardiac failure or bacterial pneumonia? Can you tell those apart on the chest radiograph easily?
So it can be tricky. Patients present with very similar symptoms such as breathlessness, maybe fever, and often these changes may be in keeping with both diseases. So I think we should clinically keep an open mind and think laterally rather than just saying this patient has COVID.
That's really important because obviously in the trial we're using a risk score which is looking at X-ray severity, but that isn't diagnostic of the disease. It is part of a bigger picture, the clinical diagnosis of COVID. I wonder if I could ask you to now take us through how the risk scoring system works.
Yeah, of course, it'd be a pleasure.
I think it's sometimes quite difficult and some of these changes may be very subtle. So I think people looking at these chest radiographs may want to ask a second colleague for another opinion and to almost come to a consensus. So the chest x-rays are scored looking at each lung independently. It's a very simple scoring system trying to look at the amount as an estimated percentage of lung infiltrates. The scoring system is from 0 up to 4 per lung. 0 reflects an entirely normal lung field. If we estimate the area of infiltrates is between 0 to 25%, that would award a score of 1, 2 points for 25 to 50, 3 for 50 to 75, and Greater than 75 is 4, so a total of 4 points per lung, equating a total of 8 points available per chest X-ray. So this is an example of a mild chest X-ray. At a quick glance, you'd be excused for saying this is normal, and I think this demonstrates that sometimes the changes can be quite subtle in COVID. It's important every time to check the chest X-ray alignment and the penetration. My eye is immediately drawn to some subtle changes at the right base. COVID often is symmetrical, predominantly peripheral and symmetrical, and I would suggest there is a small area of infiltrate at the right base, and there is possibly some changes at the right mid-zone as well. But if we're trying to map out the percentage of right lung that's affected in this X-ray, I would say it's less than 25%. And looking at the left lung, I would suggest that's normal. So a total score of 1 for the right, 0 for the left, a total score of 1. So this is an example of a moderate chest X-ray, and I think we're now starting to appreciate the more classic features we would associate with COVID. The appearances here are peripheral, they're bilateral, and they're predominantly basal. And this is what I would expect in some patients with COVID disease. I think it's important to say that there is no hilar changes suggesting lymphadenopathy. There are no pleural effusions. Again, that may be more in keeping with other types of bacterial pneumonia. When I try to estimate the area of infection or infiltration involved, I often map out with my eye or my finger the infiltration. And if I was trying to do this here, I would suggest between 25 and 50% of the right lung, and perhaps the same on the left lung is involved. So that will be a score for 2 for the left, 2 for the right, a total score of 4 for this chest X-ray. So James, this is an example of a severe chest X-ray, and we can tell that because the patient's intubated, they've got a central line in, and a nasogastric tube which is questionably advanced too far in this patient. We can see the progression here of the changes that I've described before. The changes, again, very peripheral, they're very symmetrical, but they've progressed up and are just sparing the apices of this patient's film. I think I would say that more than 2/3 of each lung is involved. That's greater than 75%, and that will be a score for the right lung of 4, for the left lung of 4, so this will be a score of 8. As this patient is already intubated, this would not be a patient that will be eligible for the tactic study, and therefore we would try to recruit this patient before they advance this level of severity.